Hello, everybody. Thanks for listening again to the Conquering Your Fibromyalgia podcast. I'm going to get a chance to introduce our second guest and our first medical doctor to be on our podcast, and hopefully more to come down the road. She started her medical career as an RN, and then she decided to go to medical school, working in the emergency department, now also working in outpatient family practice, as well as in a pain clinic in Nova Scotia, Canada. So
you have the accent.
I am the accent. So I'll try to make proper English here we can have.
Yeah.
But join me in welcoming Dr. Maureen Allen.
Thanks, Mike, for having me, and thanks for reaching out. It's been kind of interesting us trying to connect here. So always interested to talk to someone who's like-minded as I am around pain. So just a few things actually that I can help clarify is that my journey did begin as a nurse in a rural community in isolation. And I just wanted to be able to help patients more. So went back to school, became a medical physician, did a residency in family medicine, but very quickly found a complete love for emergency medicine. When I did my certification in Emerge, another colleague of mine reached out and wondered if I'd be interested in getting certified in palliative care. So I said at the time I would, and I think that kind of pulled into my nursing background, developed some expertise through that training. Very quickly, you start to get very complex referrals from clinicians in individuals who are dealing with complex pain. The traditional flow of these patients often is through palliative care, believe it or not, because oftentimes these patients are on pharmacotherapy that are not really helping them move forward in their life and are really not that effective in terms of their quality of life. So that's how I ended up in chronic pain, actually, was through that route of palliative care. So I work in a very traditional rural practice, meaning that you get pulled into different areas of healthcare. So I have some expertise in all those areas, but I think it really helps us see the whole person and be able to help distinguish individuals who are living with life-limiting illnesses versus those that are living with chronic pain versus those that are living with acute pain, and what might be the beneficial approach to those individuals, even though it may be very individual specific. So I don't know if that kind of clarifies that a little bit of that journey. Believe it or not, I also do some addiction work, but it's mostly around and which hopefully, if we do touch that, it's going to be really important, because I think there's a lot of misperceptions around substance use in chronic pain populations that often get mislabeled as having a substance use disorder. And so oftentimes I would get referrals from that population as well. But it's a fascinating area for me in terms of individuals that are using opioids for the management of pain versus those that have developed substance use disorders through the medical management of pain as well. Because both populations deserve our attention. They deserve a full court press. They deserve the compassion and the empathy that we need to provide. So it's a big bunch there, but I hope we can kind of pull all that in and maybe have a discussion in a non-judgmental, compassionate way.
Yeah.
How's that?
Yeah. And I forgot to mention Dr. Allen has a podcast of her own called Pain Talks. And that's how I actually found Dr. Allen. I thought it'd be neat to have a conversation. And the more we can have talking about evidence-based approach and empathetic approach, caring approach to fibromyalgia and chronic pain related issues. Fibromyalgia and under the umbrella central pain sensitization type disorders that goes from, tension headaches, migraine, painful periods to chronic abdominal pain, irritable. Lots of that falls under the umbrella. It's interesting, and I don't know how it is in Canada, probably a lot of similar things, but I find here in the United States, there is no true, what I would classify as a great fibromyalgia / chronic pain specialist, at least in the States here. Many family practice doctors, if they did make the diagnosis, it's very skittish. I think part of the training, and I'm an internist and a pediatrician, I'm not trying to talk high about myself, but I love learning. But I think there's not a lot of training in diagnosing and fibromyalgia and related issues. I have to have the specialist make sure that I didn't miss anything, because I don't have confidence that I made the right diagnosis, let alone if they do make the diagnosis, they don't have the confidence to really manage it well, because there's so many other things they have to. And maybe a rheumatologist makes the diagnosis, but they're not really experts in comprehensive holistic care. And the chronic pain, at least in America here, what we often call chronic pain specialists are often anesthesiologists. And many of them are doing like back injections there's probably a little bit of a financial incentive, at least in the States here, that you may get paid more instead of taking the long time that it takes to have conversations about a comprehensive approach. But it kind of leaves patients in the lurch of not getting great care and sometimes seeking less evidence-based care and sometimes self-medicating on things that may be, like I say, borderline making bad choices that are on that potentially addictive or getting maladaptive behaviors or things that may offer temporary but not the best long-term relief. Is that similar in Canada?
I think there definitely has been a recognition that education is lacking. When you think about I think it was 1996 that the International Association for the Study of Pain came out with some core competencies for healthcare practitioners around pain. University of Toronto actually was one of the first institutions that actually developed an interdisciplinary or interprofessional core curriculum course for pain, because pain is a team sport. It should never be isolated to one particular specialty. The other thing that's happening in Canada, which I think is really good, is that the Canadian Pain Task Force, which began their work probably about 5 years ago, has really started to look at the gaps and what is needed. And for many of us that work in this area, we're really starting to understand that it should never be a top-down kind of approach for pain. It should be bottom-up, because pain is a universal experience. Chronic pain affects a huge swath of individuals in our life. If I look at Nova Scotia, which is a province of 1 million people, we have over 250,000 patients who are living with chronic or persistent pain. And if you're looking at very vulnerable populations like your military, so your veterans or your Indigenous communities, that number goes up even higher. It is something that all of us involved in healthcare need to become better at in order to legitimize and acknowledge that this illness is actually very real. And I think you just talked about something, Mike, there earlier when you said about the World Health Organization in 2019 actually designated chronic pain in its new ICD-11 classifications, which isn't in effect yet, but that it actually legitimized chronic pain as a distinct illness and requiring a very distinct approach. Why I think this is so important is that it does validate that this is a real disease for patients. But I often use the analogy of insulin-dependent diabetes, that, when I see somebody with insulin-dependent diabetes, and if I just hand them over, insulin and syringes and say, see you later, see how you make out, they're going to be overwhelmed. But people are resilient. And this is what's happening in chronic pain populations is they're resilient. They're going to try and figure out what works for them. But sometimes those processes can actually keep them stuck in maladaptive coping, rather than, I always try and get them to understand, is it something that's helping you in the short term, or is it something that's helping you in the long term to live your life with purpose and connection, to do the things that you want to do? If we're just telling patients with chronic pain to go figure it out, they're going to try and figure it out. But this is where we need to get up to snuff, just like we have diabetic clinics. In Canada, I don't know about you guys, but we have pain self-management programs, which is something I feel very strongly about. And I actually do participate and teach in a multidisciplinary pain self-management program in our small rural community. So it is possible, but this is where we do need our specialists. Don't get me wrong. I mean, if you think about cardiovascular disease, we need the interventionists. We need somebody that can do a cardiac cath or can do bypass, but it's not everybody that needs those patients or needs that specialty service, right? Mm-hmm. Most of us need to be able to listen and validate stories of patients who are living with persistent pain, but also have a skill set that can help them move without flaring up, to help them understand the positive and the negative about some of the habits and behaviors that they're using. It is, to me, it's a bottom up. And I think I know for Canada is that the Canadian Pain Task Force has recognized that. And I'll share with you what we did in our own emergency department, because I think emergency departments are really important in all of this, Mike. If that's okay, if I can just mention something.
Sure.
In 2010, the value of recognizing the need to integrate how we create flow and how we get people to the care that they need that's appropriate with the illness that they have. Emergency rooms can actually serve to be a really important point of contact for some patients, especially in Canada. A lot of our patients now are really they don't have family physicians. I mean, there's still a lot of restructuring that's going. COVID's made everything so much worse. So what we did is developed a pain and addiction strategy to help patients connect to the services that they need, rather than get them stuck kind of accessing emergency departments and not really moving forward in their life. They might come in with their significant flare up and get relief of that flare up. But that became the coping strategy for them. It wasn't really helping them move forward in their life. And it was really, this is the stuff that drove me crazy, is that, we would give patients the tools, meaning that, whatever it took to get their flare up settled down. And that usually meant parental therapy, medicating the crap out of them so that they would get sedated to get relief, but then send them off on their way. And then we'd get pissed that they'd come back and expect the same therapy, but that's what we're teaching them. That's how you manage your flare-ups.
Mm-hmm.
So we were keeping them stuck in that maladaptive coping. And the most important role that we need to have when we see patients, and typically in the emergency department in particular, we're seeing patients coming in with significant flare-ups. But unless you examine that patient and lay your hands on them and take that story and listen to what they're telling, like in terms of their pain story, because they can have something new or a progression of a pre-existing disease that's going on as well. If this turns out to be that chronic pain flare-up, then we need to be able to direct them to the help that they need to manage the flare-up. But if there's something new going on, meaning acute pain, new pathology or progression of a pre-existing disease, then we need to be able to act on that like we normally should act on that. So we did publish a paper on that. It was really a framework. We were able to show in the first year that we implemented that we were able to get about a 70% reduction in patients actually presenting to the emergency room without putting an added burden on the family physicians in the community. And this is a small community. So we're not looking at huge numbers. Patients were actually fast-tracked to the pain clinic. They were fast-tracked to the opiate recovery program. Typically in a small community, we know each other, so we were able to work around that. But it was a really important juncture for our community that it could be a safe space, but it could also be a space that would help to facilitate patients getting the care that they needed so that they could move forward in their life.
I know Dr. Daniel Claw at University of Michigan, who has done a lot of research on fibromyalgia chronic pain issues. They have a module that is available online for free, and it helps give that education conversation, getting that components. He's done tons of research in there, and a lot of the understanding I have for fibromyalgia comes from people like him who've dedicated their life to understanding central pain and central pain related disorders. Can you talk about, for patients and from their perspective, we're seeing kind of higher up kind of things. There's a lot of improvement, and that's starting with education like we're trying to do. And hopefully this podcast is for a patient, their loved one, and also for doctors who just want to learn more about understanding. Mm-hmm. I've said in the last episode, for most probably doctors, when they have somebody who has a chronic pain, non-structural problem, when they see them on their schedule, it's like, oh, great. Yeah. What am I going to do for them? I have no idea. I don't know how to handle these. It's going to be very frustrated. I'm going to be frustrated because I'm impotent in helping them with substantial, and the patient may feel the doctor didn't help me at all, and very, very frustrated. They come because they fell out of a tree and maybe are worried they broke their ankle. Ton of acute pain, and there's also, like you say, overlapping chronic pain or chronic pain flare-ups. Can you talk about the understanding that patients have? You can share to help teach what the difference is about acute pain and chronic pain, and kind of the science and understanding behind it, and how to help differentiate between the two.
So I think the most important thing, though, is that we need to recognize that all pain, regardless of its presentation, is real. So what the patient is experiencing is very real to them. So our job as clinicians is to figure out, is this, especially when we're dealing with complex pain like chronic pain, so I have an approach that I use, and I can share that with you. But one of the most important things is that I need to listen to the patient's pain story, because the mechanism of their pain can be important. Is this something that is related to their chronic pain or chronic pain flare-ups? I should define actually a chronic pain flare-up, because it's really interesting. You don't find a lot of literature about chronic pain flare-ups, but I think they're really important. And I think it's often where acute pain and chronic pain gets confused. By definition, a chronic pain is an increase in that baseline pain that the patient lives with every day that increases over hours or days, and what they'll do is come back to the baseline. Chronic pain flare-ups are really important because the more that patient is flaring up, the more unpredictable, the more out of control pain becomes, until they get to a point where even simple maneuvers can give them significant pain. So what they're feeling is very real, but it doesn't always mean dangerous or bad. And that's where it's really confusing. So listening to their pain story is really important. And then acknowledging the suffering that they're experiencing, because it is very real. So that part of us that needs to come in and say, look, this is really tough. I can see that. And then what I want to do is I want to be able to examine them to make sure that there is no new pathology or progression of a pre-existing disease. And that doesn't mean that I also always do a lot of testing. And I think in the US, there probably is a ton of testing that's done. There can be a downside to doing too much testing, not only a risk for patient when you look at radiation exposure. And the US has, I think it's something like 2% of all malignancies can be linked to CT examinations in the US. There's so much CT scanning that is actually done. Most of these patients have had extensive workups, have had extensive consultations. So even prior to seeing them in the emergency room, I always try and review that information before I actually go into the room. So bringing all that together, it doesn't take a lot of time. I mean, when you're working in Emerge, I can go through their medical record in terms of looking what I need to look at in probably, I'd say 2-3 minutes. It doesn't take a lot because it's all on the computer. And I'm sure it is for you guys as well. So I have that information when I go in. So then I am going to examine them just to make sure that there's no new pathology or progression of a pre-existing disease. So those first 3 steps are super important. A lot of times patients are not, we make the mistake as healthcare providers that they're looking for drugs, right? They're looking for medication. That's rarely the experience. They're really looking to find out what the hell is going on. First of all, like, why is this pain so intense? And what can you do to give me some relief? And it doesn't necessarily always have to be about medication. It really can be about information if they're ready to hear the information. So this is the value of having all healthcare providers have some information around chronic pain. What I'll do is sit down with the patient if they're open to that. And you have to be really, because everybody, when we look at motivation and we look at readiness and all those kinds of things that are important, the last thing a patient needs is a physician to bombard them with information when they're not ready to hear it. So I have to be sensitive to that. So it may be that my focus at that point is just trying to get them relief and also helping them find other ways of getting relief. But lots of times patients just feel so reassured, even by examining them, that there's nothing bad that's happening. And I can show them their vital signs. I try and show them those objective things and also start to look at some strategies or look at some tools or things that they might be doing that are actually worsening their pain. And one of the classic ones is often the chronic use of short-acting opiate analgesics, because what they're getting is withdrawal-mediated pain. So we can have a conversation around that as well. Or we can have a conversation around how some of these medications may be actually creating, because the goals of your therapy are really to promote function and facilitate sleep at night. But if the medication is making them too sedated, making them too much in a mental fog or just not functioning, we're actually going to make their pain worse because your body is more vulnerable in those states. So if you're not moving, if you're not staying connected, all those things tend to make pain worse. So you can do that. Diabetes. I mean, if I was working with a patient around diabetes in the emergency department, and you can definitely see that the patient is having some challenges, we can sometimes focus in on that, make some really simple changes that can make a big difference in the management of that illness as well. So it really comes down to the provider having the knowledge base, and it's not complicated in my view. And I'm sure for you, Mike, it's not complicated either around chronic pain. It's just really understanding the pathophysiology and being able to put that in a context that the patient understands what's going on.
And I think there are some things that you can share that people do get. And I kind of look at a migraine headache is a chronic pain flare-up. And migraines have been around long enough that people can understand that, okay, I don't have a brain tumor. They check that. Maybe they had imaging. My doctor said, you have a very normal neurologic exam. This comes and goes, and people can go, I think, using that analogy. And at the same time, when somebody's in a severe migraine, it's probably not the best time to have long didactic discussion about the pathophysiology and the fact that they were staying up late at night, or maybe they shouldn't work third shift as a nurse in the hospital and have a newborn, or, some obviously unrealistic things that are out of their control, but how stress, how sleep, exercise, how a lot of these things could have it. But hey, we're going to get you through this short-term migraine flare-up to try to calm this down. I had a patient that saw me for a flare-up. It was new to me, but she said it turned out school started, the transition in life, and her kids were going to school. Because of that, her workout routine had stopped. She went from getting about 16,000 steps a day to about 8,000 steps a day. The stress of starting school, transition, and being a chauffeur, taking her kids from here and there to different things meant less of those good things. So in the future, she can hopefully learn. In the short term, I gave her some cyclobenzaprine to help break a little bit of the pain cycle, recognize you're in the second of the plateau stage. Using a sumatriptan isn't going to help now. Recognize some of these things so in the future that they can be helpful. And I think when you're taking that careful history, talking about it, I think a lot of times when somebody has something, you ask, what are you most worried about? Some patient may say, I'm worried I have cancer. My mom had breast cancer or lung cancer, and I'm worried that I have something. You mentioned imaging, and one of the things that happens here, probably more than in Canada, is you have patients here go, well, I have DJD, degenerative disc disease, and recognizing that's actually not really a diagnosis of your chronic back pain, but that often causes problems. Can you share how that can cause problems? Because it probably does happen in Canada as well, and you've read literature on that, but that can actually not be helpful. It can be actually harmful on the understanding.
Yeah, exactly. So let me talk about degenerative disc disease. So my philosophy on this, one of the ways that I help patients or create the conversation around chronic pain. So if I was a family physician trying to engage the patient and trying to help them understand that chronic pain is a very separate and distinct entity, is that I get them to itemize. So tell me what you've been told in your pain journey that is contributing to your persistent pain. Degenerative disc disease, degenerative arthritis is very common. And you know what? So what I've learned is to embrace that for the patient. It doesn't matter that it doesn't cause persistent pain. Degenerative disc disease, degenerative arthritis. They also may have a condition where I was involved in a terrible car accident when I was 16 and I had a broken bone. So that is part of their journey, broken bone. Or they have a condition, underlying condition like rheumatoid arthritis or Crohn's disease. So that is a condition that they believe is contributing to their persistent pain. And then what I do is separate out the chronic pain. If you have chronic pain, it's going to create some complexity. I'm going to show you why. So how do we treat degenerative disc disease and degenerative arthritis, Mike? We get people moving, right? We want them moving. We want them to have strong tissue because it's not about their bones, it's about their tissue. But if you have somebody with chronic pain, when you try and get them moving, they're going to get worse. If I say to a patient initially that I want you to walk 15 minutes twice a day, they're going to try it because they want to get better. But most of these patients with chronic pain will actually initially get worse. And the reason why is it has to do with that pain alarm. So how we get them moving, because we do want them moving lots, but we have to get them moving in a way that is predictable, it's safe to them, right, to their nervous system, because, walking 50 minutes twice a day is not going to feel safe if someone's flared up when they tried it for 5 minutes, right? So it's important that we see the chronic pain as a separate entity from the other pathology. So how do I distinguish between Crohn's disease and persistent pain? Crohn's disease is obviously an inflammatory autoimmune process. We use markers, different types of biologicals, immunotherapies, and we try and trace that disease using scopes, all that kind of stuff. So this is how I know that this disease is relatively stable. But what you're telling me is that your pain is much worse. It's trending upwards, that no matter what you do, things get worse. So that's probably more tied into that neuroplasticity around persistent pain. Sometimes it allows the conversation because it gets so confusing in some of these very complex patients, but to separate out the chronic pain from what they believe is contributing to their pain through their journey, because they've seen multiple specialists, they've been given multiple bits of information. And you know what? We need to see that as part of their story and let them own that. But then we want them to see the chronic pain as something totally separate that's contributing to their decrease in quality of life. And how we approach chronic pain, one of the worst things we could do is to keep somebody in an acute pain model that has chronic pain, because they will get worse and they will feel that they have failed they'll fail their families. Families don't feel they're trying hard enough when in fact they are really trying. It's just that we're not really understanding the neurobiology around the persistent pain and how that alarm has become hyperprotective and hypersensitive, even though it may not mean dangerous or bad happening in their tissue. It doesn't matter. It feels like dangerous and bad.
To add to that, you mentioned that acute pain model can add so much complexity. You and I have breathed a lot and read a lot in chronic pain research and literature and understanding and caring about this. But for the patient who hasn't had it and is trying to glean from us, it can be overwhelming. And one of the examples where these intersect is acute kind of pain where somebody has Achilles tendonitis because they started walking more. The snow melted in Nova Scotia and Wisconsin, and people are gained 20 pounds of weight. And now they want to start walking every day. And maybe they don't have the severe fibromyalgia type stuff, but they start getting a tendonitis in their Achilles. It's very classic. And we say, okay, you need to back off on your walking. You overdid it. You can't walk 5 miles a day. It's too much. You went too fast. But at the same time, that could aggravate their chronic pain unless we said, try to do a stationary bike. Can you try swimming or other options? But that gets to be very confusing and complicating. What's good for one thing, and especially as I get older, cross training, doing multiple activities is so much more important than just run every day 10 miles.
So the other thing that I see, and this applies to both acute and chronic, and I'll give you an example. So I call these pain protective behaviors because our brain is not only designed to pay attention to pain, it's also designed to get relief from the pain. This is a very subconscious response to how our body behaves with pain. If you think about acute pain, a classic example I'll see in the emergency room is somebody injures their knee and they walk into the emergency room they don't want to bend it. They're too afraid to bend it because it's going to hurt. And they're walking really bizarre. I stop them actually and say, look at how your body is adapting to this pain. And just imagine how that's affecting other parts of your body, like your back, like your hip. And so what your body is really telling you is that you need crutches. You need a way to get off that ankle and to use those crutches in a way that that you're not going to aggravate things, right? But in chronic pain, it's really interesting. So once the body heals that tissue, so the normal progression of acute pain tells us to pay attention, tells us to protect it. As body heals the tissue, pain intensity should reach a peak and then it should go away. With chronic pain, what happens is that those pain protective behaviors can become maladaptive. So sometimes we just need to bring it more to that conscious part of our brain rather than let the unconscious part kind of try to give us that relief and take over.
And I think that is an example of two intersecting issues of a mechanical aspect for many people where they do have significant lumbar spinal stenosis and they're older, where it is truly causing a radicular mechanical compression where they have to lean over. One of the things that they may, out of pride, is not want to use a supportive walker because they don't want to look like an old person. I kind of have a joke with my patients. The problem with my older patients, I'm going to be cursed with stenosis if I live long enough myself, but is the problem with walkers is they make you look old. And for those who need them, one of the things is like, hey, but you can do a stationary bike. And can we do more of that? Can you do a recumbent bike before you get too weak? Because what happens, and this is very common, is when you look at the percentage of prevalence of per decade of life goes up with chronic pain, is probably as we do have some mechanical things that are barriers to being as active. We don't realize, we think, I can't do that. And it was always one of these things in medicine. I know as a doctor in the 90s, there were these studies and I couldn't explain it, but you just had to take it at face value. Exercise helps people who have arthritis of their knees. And from an athlete who has had stress fractures and overuse injuries over the years as a young person, well, exercise, you needed to rest. You had to shut the athlete down who wants to exercise so much. And yet, when it comes to chronic arthritis, regular exercise is so important, and then telling them to have to be active. So what can be good advice in one situation can be bad advice. My daughter just rolled her ankle, stage 2 ankle sprain. She really, really wanted to go and try to keep going, but you have to let the ankle heal.
Pain is protective. It's it's one of the reasons why humans have, I think, outlived most other species. Not to say other species don't respond to pain, but it's such an important part of how we're hardwired to survival. What our physiotherapist calls walkers and canes are pieces of exercise equipment. So she frames them in a way that's much healthier. And one way that I can get people to buy into, supports when they're walking is to think about using walking sticks. Now that becomes a challenge if you want the person off the extremity, but for some patients with chronic pain, it's really about feeling safe when you're moving and to have some supports as well.
And I think one of the things that we recognize with therapy is that unlike other medical conditions, and I've talked this on other podcasts where you can take the appendix out and you're cured, there's so many partial approaches. There isn't one of the interventions that's going to, in America, most of the interventions are partial, maybe a single or double. And it's a complement of things, and it's doing it the right way. Like, you don't just give a bunch of insulin, take a 50-unit dose of short-acting insulin. That can cause problems. You don't have somebody get 18,000 steps when they're barely doing 500 steps. That's going to cause problems. And you see where they're at, and then have this gradual program, and then talk about it. Part of the whole podcast that you do, and for myself, and part of the reason why I wrote the book, is to give that information. And the second chapter of my book is called The Buy-In. A lot of this is trying to filter through this idea of central pain sensitization, legitimize that it's real, but it's not to the point where you're imagining this. This is just in your head. And can you just go away and just get out of my office? Unimagine it. And I have real patients with real problems, and I'm going to try to prevent a real heart attack.
When we think about cytokine surge and the function of glial cells. So I find the neurobiology, and in fact, when I do the pain self-management program, I do the talk on, what we understand about what the mechanism behind this, as well as the pharmacotherapy. But I bring in the glial cells and the whole thing around the pro-inflammatory, the cytokines and chemokines, because it is so fascinating. And even how patients respond, it starts to make it all like, wow, our nervous system can do that. Yeah, our nervous system has the ability to change and adapt based on information that it's processing. So the beauty of that, when you understand that, is that it can change in one direction, but it can change in another direction. So we have the ability to actually dial down some of how these cells are functioning just by changing one. That knowledge is possibility. It only has power if we use it, but it only has power if we're ready to use it or know how to use it. So that's the knowledge translation as well as the readiness piece, right? So when people start to understand, and especially if they're ready to kind of process it, they're like, wow, okay, this is very real. Yeah. So
yeah, and I think, and that's part of, and I've had patients and people share with me who've read my book to try to give a much more in-depth understanding, wow, I can identify with that 85%, and it helps put some context to this, and they can understand. We talk about things that sabotage things with the whole COVID long haul kind of thing. I think there's an overlap of the anxiety and fear that I have something serious. And sometimes it's that I have bad DJD, so I'm a brittle person. I can't exercise. And that starts that downward spiral. I think it brings up the part of anxiety. To me, in my mind, anxiety and pain, I look at, are both alarms that are protective. And that can be good. But when the alarm goes off, it can create the body at a hyper vigilant state, which is inappropriate for normal living when you don't have an acute pain. And it's these overlapping of these things with the central nervous system going off. There's a lot of overlapping with things like ADHD, anxiety, poor sleep, all of this. And then you talk about external forces of fear of unknown. What is this COVID going on? Stress of somebody who's living in a spouse in a situation. One of the fears I have is that there may be people who are living in a high stress environment that's out of their control. Extremely, my heart going out is where it's simple, but I can't put those implements in. I have a special needs child. My husband's struggling with, or spouse is struggling with a substance use. They're caring for an aging parent. All of this wrapped in with, oh my gosh, there's so much going on that to completely control it. And I'm sure that's where you see that, where there's situations where there's limits in certain people with their individual story.
Well, I mean, you have to look, I mean, there's a couple of ways to think about that. I think humans by nature are resilient human beings, but sometimes, the vulnerabilities are higher than the resiliency, right? So you're trying to fill the tank of resiliency up by giving them skills. I often tell patients that, especially when they just feel like they're crashing, when a patient just is in a terrible place and they just feel that, if anything, and where we often see this, I like to think of some individuals as what we call boom and busters. These are people that are just go-getters. They've always been go-getters. They've worked really hard their life to get along in life and then get hit with chronic pain. And when we start to tell them to pace, meaning that we want to pace their activity, they actually feel like they're going backwards, and they start to feel more depressed and they feel like they're losing control. But what I try and tell them is that what's happening is that your body is trying to say to you and your mind is trying to say to you that the strategies that you've used to manage your chronic pain or your life at this point are not working. That what we need to do is to find another way. So, in part of you is almost mourning the loss. It's almost like a death in some way. It's sort of a form of grief that I'm not going to get back to where I was, that the strategies that I've used are probably not working anymore and I need to find another way. So part of that unsettling time is often them trying to find their way back forward. And that's where we need to really be able to support it. It's not to fix it because it has to work for them. Our brain is constantly looking for calm, Mike. And I think you would agree with that. Our brain wants calm. It needs calm in a predictable way that feels safe. And that goes back to evolution, right? If we're in this hypervigilant state, that's not a healthy place to be because we're always constantly looking and there's no saber-tooth tigers anymore kind of thing, right? So so the brain needs and wants to find calm. If we're not able to support patients and help them find that calm, they're going to try and find it themselves. And this is where sometimes substances come in, right? Especially the short-term benefit rather than looking at the long-term benefit, right? It's much easier to reach for something short-term than it is to find skills and strategies that help to dial back the pain intensity that they're having.
Yeah.
So I think it's important to, I mean, the hardwiring, I do believe in, I mean, it's fascinating to me, some of the literature, when you start reading, just talking about sort of that evolutionary piece of humans. Humans are designed for connection and they're designed for movement. So and chronic pain is a very disconnecting illness, especially when they're acutely into it. But what happens is that when they become more disconnected and less functional, the pain actually gets worse, even though that's one way that they're trying to find calm is if I don't move as much, if I don't go out, but actually the more isolated, the more disconnected, the less mobile they become, their actually pain will start to get worse. And then they start to become a little bit more pain focused, right? So getting more function focused is going to be really important, but that brain is always going to try and find calm any way they can. So this is where we can help.
Yeah. And I think starting with education, it can be really tricky. And that's where appropriate medications that can help sometimes lift from extreme to moderate to severe to allow some of these. It can be for those who don't have fibro but have a spouse who have this. It is completely irrational how a good thing of gentle touch on their spouse to them is excruciating pain and some extreme levels of chronic pain, fibromyalgia type conditions, that what was meant to be a calming good thing is overwhelming. The community experience of in time together, even that is perceived as extremely uncomfortable noise, and trying to help ease back in. I've had many patients, and this isn't necessarily in a study, but I got this from a study from Dr. Clown, University of Michigan, who's done tons of research in fibromyalgia related issues. He said that most of his patients who have fibromyalgia were extremely active when they were younger, and something gets taken out from under them. I talk about a patient in my book that she was working in a factory on her feet. She'd go to the YMCA and work out for an hour, and she got an anaphylactic reaction to a bee sting, was on a ventilator for 5 days. And when she woke up, they started chasing lots of things like an elevated liver enzyme, which was really her chronic fatty liver. Because she was so sedentary so fast, the normal pain suppression processes that exercise did to turn down the amplifier got completely shut off at a level and persistence so fast that we had to talk about some of these other things. I do think looking at research supports that there are a lot of comorbidities with chronic pain. This person also had an ADHD aspect. She had a job that was highly active and didn't require a lot of or things that somebody with she would struggle with. And she had a hobby that was very active. So a lot of times, like you say, somebody that's chronic pain, they used to be active. They used to play as a kid in their free time in the summer. They might have played hockey in Nova Scotia and kept busy all the time. And something happens that they got promoted to be a supervisor, which means they're sitting. They're not walking around the factory. They are pregnant and now it's too hard to exercise. Or maybe the OB said, well, I don't really think you should exercise much during pregnancy. You've been training for half marathons and, why don't you back off? And then she starts to spiral, and having this is the research shows a susceptibility, and then you put them in the environment. So as Dr. Claus talks about in one of his talks, he said he can take a trip where he volunteers in Africa and he doesn't hardly feel achy or sore because he hardly ever gets chronic pain. But you take the same patient who's susceptible, put him on a plane, jet lag, time schedule, lanes, it's 24 hours of sitting in an airport or airplane. Suddenly that's enough to flare it up. And those susceptible person, where the person's spouse may not be susceptible. But if you can try to anticipate some of those, have that awareness of this is what I need to feel normal. And I think there's so much more. And you have a lot of really good podcasts online already, going with great interviews and discussion about chronic pain related issues. So you can check Dr. Maureen Allen's podcast out. Encourage that to help give evidence-based approach to help with things. I think one of the things, just like you said, to end maybe with, is that these are real conditions. These are real people. There's real suffering, but there's real hope that there can be an understanding. I think it starts with an education and real good evidence that helps and hopefully encourage more physicians to learn more about this, that their doctor can help. And I think a lot of this, and playing a lot of sports in my life, I appreciate the value of a good coach. And I think what I've learned from that is to have that positive, supportive, encouraging, coaching, empathetic approach to helping those that are going through this. And that's the best case scenario.
Yeah. And I'll just mention, because it is very, very similar to me, Mike, in the sense that when you are in this business and you're like, my God, I wish we could create some dialogue with other colleagues or link things for patients to see that there is possibility out there, like that hope piece. And I think that for me, that was the whole thing around the podcast that I decided. But I just want to share, it's as scary as hell to try and do something like that. And I'm sure you felt the same way to kind of put yourself out there. But I do think it's important to have that dialogue and that we start the conversation somewhere. And because there is a lot to be hopeful for. I think there's a tremendous amount of research happening in this field, and we are we've got some incredibly smart people that are working in this area, researching this area. It hasn't been as good as I think it could be, but I do think that there are reasons to be hopeful, down the road for sure.
I mentioned on a podcast a couple of times ago, I use one of the assessments called the Fibromyalgia Impact Questionnaire Revised. And I think one of these is, I think people are so used to having a all or none solution to their problem and not recognizing there was a 20% improvement on a duloxetine and your score improved, but they're expecting that it went to zero. And that's usually not the case. Or when they got their steps up to 10,000 from 2,000 over a 6-month period, that their score improved from a FIQR of 65 down to a 40, which is like, hey, that's improved, but I'm still in pain. I know, but you're improving, and look what you can do. I had a patient of mine who I mentioned on the podcast. She has a complication of a surgery with a hip replacement, didn't go exactly right, some neuropathy after that. I only get a chance to see her once a year because she lives part of the year in Arizona. So from 2 years ago when I first met her, pretty short after the surgery, still in a very frustrated state, didn't go as planned. A year later was doing a little bit more. And now a year, she says, like, well, my husband likes to go golf. I can't golf with him, but I like to go shopping. I'll go shopping. Well, what's cool about that shopping is that you walk a little, stop a little, walk a little, stop a little. It's perfect. Then that get on there, power walk, get out there, that intermittent movement. And then she said, and I'm in the swimming pool and I feel so much at ease. I'm in the swimming pool. And I said, well, that's great. You're doing so much better. You have improved. I mean, when I met you 2 years ago, there's improvement. Is there still frustration? But I think that's that coaching encouragement of pointing to that there is some, it's just balance.
Yeah. And I'll mention the paper because I think it's worthwhile. I mean, I've given this paper actually to patients by Kevin Fleming. It's central sensitization and the initial evaluation of patient with fibromyalgia. But what is so good about it, and what I found, especially around complex, multiple unexplained symptoms, is it really does validate, and it is an online access paper, but written by Dr. Kevin Fleming, and I forget the nurse, I think it's Nora Volchek, or I'm probably mixing that up. But it's a really interesting paper. And I have shared that with patients as well. And patients are so knowledgeable and they just do so much research. I said, hey, just have a look at this part because this might help explain it too. Anyway, we could go on forever.
All right. Thanks a lot again and enjoy. Thank you for taking your time away and joining me in Wisconsin from Nova Scotia. It was a pleasure to talk with you. Bye-bye.
Well, take care, Mike. Thank you so much.
You're welcome.
Okay.
Bye.